Hello and welcome all to this week's Journal Club. So today we've got a presentation about the Cesar Trial. So we've got Dr. Serbi and Dr. Lisa who are going to speak about this trial. So I'll hand you over to them now to start the presentation.
Thank you. Good afternoon. So the presentation topic for us is about Cesar Trial. Now, this was a very famous study which was published in Lancet in year 2009. And Cesar basically stands for conventional therapy versus ECMO in severe adults with severe respiratory failure. So, why did they decide to do this study? Before the study was conducted, it was found that there were very few randomized controlled trials that were done with ECMO in adults with severe respiratory disease. So the earliest study that was conducted using ECMO was in 1970 in US by their NIH. And in this study, they found that basically the patients who were treated with ECMO had no survival advantage over patients who were treated with conventional therapy using basically mechanical ventilation. And they found that in both the groups, the survival was poor. Now, this study had a certain drawback as far as ECMO was concerned. The thing is that they used veno-arterial ECMO, which is associated with higher incidence of pulmonary thrombus and pulmonary fibrosis. Also, they use very high pressure ventilation, and that beats the purpose of ECMO because for ECMO, you need the pressures to be low for the ECMO to be working good. And also, they tended to use higher amounts of anticoagulation, because of which more number of people died in ECMO group due to bleeding. So for some time, they did not use ECMO in adult patients with respiratory disease. So in 1992, there was another randomized controlled trial conducted in US again, which used a form of ECMO that basically removes carbon dioxide from the body. Again, they found that there were not any significant differences between the groups who were treating with conventional therapy, including mechanical ventilation, and patients who were treated with ECMO. There were again some drawbacks with this study. This study again used very high pressures for ventilations, which again beats the purpose of ECMO, because for ECMO you need to be resting the lungs on low pressures. They used low flows of ECMO in this study, which was not appropriate for those patients. Also, they tended to use something called as inverse IRV, inverse ratio ventilation, and it showed very good effect. And that is after this study, this IRV ventilation became very popular. By the time we were reaching the year 2000, a lot of advances were made in ECMO in terms of the kind of membrane that they were using, the kind of anticoagulation that we were using. So ECMO became a lot much better. So by 97, the researchers in Glenfield decided to conduct a cohort study on 50 of their patients. And this study found a survival advantage of almost 66%. So that was encouraging. And also then a UK collaborative RCT was done using ECMO on neonates with severe respiratory disease. And it was found that ECMO was useful in these patients. So after this RCT, it was felt that they need to do a similar randomized controlled trials in adults as well, which is why they did Cesar study. So this Cesar study was conducted over a period of 5 years, from July 2001 to August 2006. There were 3 types of centers which took part in this study. One was the ECMO Center at Leicester. The other were CTC, that is conventional therapy centers. They were basically hospitals that could provide positive pressure ventilation and hemodialysis to the patients. And the third type of hospitals that took part in the study were basically the referral hospitals, which sent patients that could enter into the study to the CTC centers. Now, what were the inclusion criteria for this study? They included patients who were aged between 18 to 65 years, having a reversible respiratory disease. Now, the reversibility of this disease was basically decided by 3 consultants in the Leicester Hospital. So they decided whether the patient has a reversible disease or not, and then the patient was included in the study. Also, they had to have severe disease, which was decided based on MEIER score. Now, the MEIER score was something that was being used during those days to define severe respiratory disease. We did not have the Berlin's criteria for ARDS that we use today. So they had to use MEIER scores at that time. Also, they included patients who had hypercapnia and were acidotic due to it. So their exclusion criteria was basically patients who were ventilated for more than 7 days with high peak inspiratory pressures of 30 centimeters of water, or with high FiO2 requiring more than 80% FiO2. Also, they excluded patients who had high intracranial pressure and patients who were, had contraindication to heparin. So these patients who entered into the study were basically randomized into 2 groups, either ECMO group or the group which called as a conventional therapy group, named as CM by them. Now, how did they randomize their patients? This was a bit of a controversial aspect of this study. They followed something called as process of minimization for randomization. What they did was, when the first, they admitted the first patient into a certain into the arm of the study based on simple randomization. Now, the second patient could be to enter, the next patient who entered had to meet the balance based on certain criteria. The criteria was based around the type of center, the age groups of the patient, hours of high ventilation, whether the patients were hypoxic or hypercarbic, or the number of organs failing. So based on that balance, the patient was then decided which arm the patient is going to go into. Also, sometime in the middle of the study, when they had almost recruited their 40% of the patients, they decided to introduce an additional step. What they did was that they said that if the center was in admitting 4 patients into a particular arm of the study, the 5th patient could not enter into that arm. The 5th patient had to go to the other arm. So whether this was a good thing or a bad thing, it is a subject of debate. So what were the interventions in 2 groups? For conventional therapy group, they could receive any therapy which the consultants in the centers felt was appropriate. But the thing that was not allowed for them to do was to cross over the patients to receive ECMO. Also, it was recommended by the authors of this study to use low volume lump reductive ventilation strategy, but it was not essentially followed, because this was not it was not in the protocol of the study. So, and the ECMO group, now again, the ECMO group were initially, their strategy was to treat these patients with low pressure ventilation. And if the patients improve, that is, if they did not have high pressures or if they were not requiring high FiO2, then it was decided that these patients will not receive ECMO. So in this study, the ECMO group had certain number of patients who did not actually receive ECMO. Also, the group of patients who had high pressures or who had high FiO2 requirement, after a period of 12 hours, were then entered into, were then given veno-venous high flow ECMO. Also, they were aiming to give lung some rest when these patients were placed on ECMO. They decided to do this by keeping the peak inspiratory pressures below 25, by keeping the peak below 15, by using low respiratory rate of around 10, by aiming to reduce FiO2 to 30%, and keeping IE ratio of 1:1. Also, they used diuresis, steroids wherever required, and also patients, if they were in liver failure, mass therapy was given to them. So on ECMO, when the weaning was decided on the basis of improvements made by the patient on chest X-ray, or if they were having lung compliance improvement, or if their gases were improved, then it was decided to take the ECMO cannula out. Now, what were the outcomes that they were measuring? Their primary outcome was to look at deaths at 6 months or severe disability at 6 months. And they said how they defined severe disability was, they said that the patient is severely disabled if the patient is bound to the bed, or if the patient is not able to bathe, or if the patient is not able to dress himself or herself. So this was the primary criteria. They were also looking for secondary outcomes, like how much of duration of ventilation were the patients on, whether they were given any jet ventilation or high frequency oscillation, whether nitric oxide was used on them, whether they were prone, if the steroids was used on them, and the length of ICU and hospital stays. Also at 6 months follow-up, they looked at quality of life improvement made in these patients, if there were respiratory symptoms, cognitive psychological state, and also lung functions assessed by spirometry. Sample size. Now this was another controversial aspect of this study. Initially, they decided that, well, they expected patients to have a mortality of 70% or 10% risk of severe disability by the end of 6 months. So if we were to assume this, they decided that the sample size should be 240. That is, 120 patients should go in each group. And they said that if they do that, this will be able to detect a reduction in the rate of primary outcome, that is mortality or severe disability, by almost 25%. Now they start this study in 2001, and by June 2003, in the middle of the study, a data monitoring committee decides that no, we want to lower the sample size from 240 to 280. That is, 90 patients will go to each group. Why they did that? They justified that the primary outcome, that was mortality, in the control group was 67%, which is still close to 70% mortality. So they can do this reduction in the sample size. And they also said that if they do this reduction, the reduction in the rate of primary outcome will still be by 1/3. So that is how they justified this decrease in sample size in the middle of the study. Now, coming to the results, there were some 766 patients who were actually considered eligible for this trial, but some of them could not get the ECMO bed. Some of them had low MEIER score or had high pH. So ultimately, 180 patients were randomized to enter into the trial. 90 patients were entered into the ECMO arm, and 98 patients entered into conventional ventilation arm. In the ECMO arm, 22 patients did not receive ECMO because some of them died or some of them improved because of the lung protective ventilation. So 68 patients actually received ECMO. Out of these 90 patients who entered into ECMO arm, all of them agreed to give feedback after 6 months. So they were available for assessment of primary outcome after 6 months. But in conventional ventilation group, out of 90 patients, once they came out of the ventilator, at the end of 6 months, they decided not to give data about themselves. So they basically dropped out. And they did know that the patients are alive, but we did not know whether they have severe disability or any other parameters about them. So if you look at, this table basically compares comparability between ECMO group and conventional therapy group. These both the groups were compatible in terms of the hospital, the kind of hospitals that they entered, in terms of the gender of the patients, in terms of the age, in terms of the diagnosis at the entry, number of organs that were failed, or the duration of ventilation. the thing I want to draw your attention towards the lower part of this table. In the ECMO group, out of 90 patients, there were 85 patients who entered into this group because they were hypoxic. In the conventional therapy group, it was 87 patients who entered into this group because they were hypoxic. There were 5 patients in ECMO group who entered into this study because they were hypercapnic and had high pH, had a low pH. And there were 3 patients who entered into conventional therapy group because they were hypercapnic. Now, out of these 85 patients in ECMO group who had hypoxia, all of them met the ARDS criteria that we use today. That is the Berlin criteria that we define, that we use for definition of ARDS criteria. Out of 87 patients in conventional therapy group, 85 patients met the ARDS criteria that we use these days. 2 patients were the one that met the ALI, that is acute lung injury criteria. Coming to management after randomization. So ECMO patients, I already mentioned that there were 22 patients who really did not receive ECMO. Their patients in both the arms received high frequency or jet ventilation, received treatment with nitric oxide. They received proning whoever required it. They also received steroids whenever required and received veno-venous hemofiltration. Also, there were patients in ECMO arm who had liver failure and they received MARS therapy for that. Now, if you look at the lower 2 rows, you will see that there are patients in ECMO group who received low volume ventilation. There were 84 patients who received as compared to only 63 in the conventional therapy group. Also, these patients who received this low ventilation therapy, they received it for higher number of days as compared to conventional ventilation arm. And this could have been a source of bias in their results later. Coming to primary outcome, I want to just say two sentences about p-value. Now, p-value in a study, whenever it is less than 0.05, it is significant, meaning there is a statistical difference between the 2 groups. And whenever it is more than 0.05, it means it is not significant, meaning the 2 groups are similar. Now, if you look at severe disability, you will see that there was only 1 person in conventional therapy group who had a severe disability, and none of the patients in ECMO group had a severe disability. So basically, there was no difference between the 2 groups. If you look at death, if you look at the number of deaths, there were 63% of the patients who survived in ECMO group as compared to 50% patients in conventional therapy group. If you look at this figure, you might feel, oh, fine, so the patients in ECMO group were actually surviving better. But no, if you look at statistics, the p-value was 0.07. That means there was no difference between the ECMO group and the conventional therapy group. So they combined deaths with disability. When they looked at this parameter, they found that 63% of the patients in ECMO group survived compared to 47% patients in conventional therapy group. They also said that significant because the p-value was less than 0.05. The numbers, the relative risk was 0.69, which means if we treated 7 patients with ECMO, then we could prevent death or disability in 1 patient by the end of 6 months. But something that the authors did not mention here was about the 3 patients that I was talking about earlier. There were 3 patients in conventional group who refused to give their data after 6 months. If we consider that they did not have any severe disability, then this data is true, that there was ECMO had survival and disability advantage over conventional therapy. But if you consider that these 3 patients were severely disabled by the end of 6 months, then the p-value becomes 0.051. That means there was no difference between the group, meaning there was no survival advantage of ECMO over conventional therapy. Coming to another thing to notice here is that the number of patients who survived on ECMO, whose died due to respiratory failure in ECMO, were much lower as compared to the ones in conventional therapy group. Here we are looking at Kaplan-Meier survival curve. Basically, this looks at probability of survival versus the number of days. So the curve in the bottom is the one for conventional group, and the curve on the top is for ECMO group. So if you notice, by around 20 days, the probability of survival becomes less than 50% in conventional group, whereas it remains higher for ECMO group even after 200 days. So more number of patients were basically surviving in ECMO group for a greater period of time as compared to conventional group. And also the time to death was shorter in conventional group as compared to ECMO. Coming to length of the stay, patients who were allocated to ECMO, they were found to spend longer time in critical care and in hospital as compared to those with conventional therapy. Lisa will speak about economic methods and
yes, so the second part of the Cesar trial looked at health economics and whether ECMO was actually potentially economically viable. They looked at the cost utility at 6 months. So they spoke to most ITU units asking for their budgets, staffing costs, disposable costs, including ECMO, looking at transfer cost from ambulance units. So they looked at a lot of different parameters about money, and they looked at cost effectiveness, so survival without severe disability and that cost itself, and then cost utility, so looking at the QALYs, looking at based on questionnaire responses at 6 months. So pretty much the economic results. So just looking at straight figures, the average total cost for an ECMO patient was nearly £74,000 versus the £33,000 for conventional management. And the additional cost of a survivor ECMO is massive. ECMO does give 0.03 extra QALYs, so that makes a cost per QALY of ECMO of 19,000. So if you consider that this is cheaper than a single lung transplant, which means that they felt it was economically viable. However, the cost to the patients and relatives were much higher in the ECMO group, given that the centre was not necessarily the closest to the patient. There was a longer length of stay, so patients and relatives were massively out of pocket from receiving this treatment. So a few discussion points now. So as they hypothesised, the transfer consideration of ECMO reduced the proportion of patients who died who were severely disabled at 6 months by approximately 1/3. So they nearly proved what they wanted to. However, the time from randomisation to death was much shorter in the conventional arm. So looking through the study, there was no standardisation of when to withdraw care. They felt that was very varied in the control centres, but they had very strict criteria at Glenfield of when to withdraw. As Serbi discussed earlier, the randomisation to balance the numbers for different factors to make their arms equal potentially could cause a little bit of bias. And there was no standardisation of care, as you can imagine, would be very difficult in the control ventilation centres, but that probably gives a more accurate representation of care across the country as opposed to one centre. Again, although the outcome from ECMO was improved, there was no transfer required in a lot of the conventional arm. So we do need to remember that 2 patients died in transit. One of those was from oxygen failure, which presumably was completely avoidable, and a massive cost for that patient and family. They felt that ECMO significantly improved health outcomes at 6 months. However, they did make massive assumptions that people would continue to make progress up to 2 years. So the people wouldn't change between 6 and 2 years, which is a big assumption, especially when we're coming to QALYs down the line. So looking at the strengths of the trial, so there was some early assignment treatment groups. The patients didn't have to wait long before being randomised, and they did incorporate some risk into the trial design, and they looked at an awful lot of economic data to look at their analysis for economics. The 6-month follow-up was done in the patient's home, ideally, by trained researchers, so it was blinded at that point. Patients tried to avoid telling the researcher exactly what had happened, and they covered any cannulation scars, so all candidates wore a scarf to cover cannulation status for ECMO. So trying to reduce any bias or issue from the 6-month follow-up. However, there was a few concerns about this trial study. It was incredibly difficult to make sure that this was completely perfect, and it's a problem with every trial. But these were just a couple of things that we saw and that we'd researched around. So the study was more about treatment in a single specialist centre with potential for ECMO. So with regards to the ECMO centre, we didn't have any variation in care. It was very standardised, whereas the conventional group had a lot more freedom from the treating clinicians. Only 76% of the ECMO group actually received ECMO, so it was an intention to treat rather than what the patient actually got, which would be appropriate if there was a bigger dropout rate, but there was only 3 patients that actually dropped out of analysis. And then, as I said before, there was no management protocol for the patients randomised to conventional ventilation. And we found that the intervention group had a higher proportion of being treated with lung protection ventilation as opposed to those in the control in the regional centres. Like I said, intention to treat analysis is useful when you've got, when there's more loss to follow up. The other big problem was there was over 100 patients that would have been eligible to enter the trial, but they had no beds available, which is a potential concern. So then a couple of conclusions. So the Cesar was a pragmatic trial, and the authors are very open about that during the write-up, that showed a significant reduction in mortality and severe disability for patients with severe reversible respiratory failure. It does seem to be cost effective, although 100 patients couldn't enter. To potentially make it better, the authors felt that a national adult ECMO service was needed. Now, we've got more facilities now, given that this was written such a long time ago, but that was what they really wanted to do. So there was a few priorities that they wanted to feature in the future. So a long-term follow-up of these patients, which would hopefully help with some of the economic data and accuracy for the future. They wanted to look at Nova Lung, which was CO2 removal. Now, one of the patients in the conventional did receive this treatment, which was against the study protocol, so was removed from analysis. And other centres are now doing multi-centre RCTs of ECMO in children, which hopefully we may be able to extrapolate some data from. So that's the end of what we had to talk about. Further on in the presentation, which you'll be able to access later, has some bigger tables, but there's just an awful lot of data in there that we didn't want to bore you with or go over in great detail, because there's just a lot to talk about. So if I can, we'll take some questions.
Yeah, thank you very much for your presentation, Serbi and Lisa. Very interesting presentation. So have we got any questions from the audience? At this point, you can unmute yourself or put it in the chat and I can read them out. So I have one question for you guys as well. So looking at the study, what do you think the reason was that they then had a non-statistically significant difference between actually looking at just deaths or looking at morbidity alone?
Well, that was statistics. That's what they found out. So this is so this is what it is. So this was another drawback of their statistical analysis, if I can put it that way. This thing that they did of combining disability with deaths and not just reporting deaths alone or not just reporting disability alone. This thing is called as composite analysis. And they had, my guess is they probably needed to do it because they found that there was no such statistic difference in their in terms of deaths or in terms of disability alone in both the groups. So that is when they decided to combine both death and disability and then report it. And then that is when they found that that the result was significantly different.
I do wonder if it's because of the power of the study, and maybe they didn't recruit enough people into their study because they did want to have a greater proportion of people before. But of course, due to availability of beds, they were unable to do that. So
yeah, potentially if they'd managed to have achieved their initial targets, we'd be able to get more accurate data and be able to prove a bit more convincingly about the benefits.
Yeah. So we've got a question from Dr. Mlanjam, who says, based on what you've presented, would you refer your patients for ECMO?
I think it's still got an awful lot of risks. So looking through it, yes, it wasn't a cut and dry that this is going to be a massive benefit for the patient. I think we've also come a long way in terms of how to manage our patients appropriately. And looking at some of the interventions that the ECMO centres initiated, so proning, APRV, steroids and more diuresis are things that we're doing more and more now. So it may be that potentially we need to look again at this and potentially if they've got to the last resort, if there's nothing else, yes, resort to ECMO. I'm not quite sure of the timings of when the best point would be though.
Yeah.
Okay, thank you. Has anyone else got any questions? Otherwise we can end it there.
Me and Augustine sent one, but by text.
Oh right, okay. Let me look.
I could probably just say it, but
yeah, just say it if you want.
So in the trial, it was peak inspiratory pressures that were used. Do we now use mean inspiratory pressures? And how was the peak inspiratory pressure chosen in the trial? Was it a one-off or an average over so long? How did that work?
Oh, so they actually, what they wanted to do was use the plateau pressures, but they found that it is not practical because not everybody on ITU knows how to measure that. It requires a bit of knowledge. So that is why they targeted the peak inspiratory pressures, because they knew that if they target peak inspiratory pressures of 30, obviously the plateau pressures were going to be less than 30. So they would have achieved their lung protection by doing that.
Okay. Thank you.
Thank you.
Have we got any other questions before we end it there?
Well done, guys. Complex paper, heavily criticized by intensivists all over, but it still has its place as what, its timing of when you would refer. But yeah, well done.
Yeah,
Thank you.
Thank you very much, and we'll see you guys next week in the Journal Club.